Welcome to PCA Study Review, a service of the Pennsylvania Chiropractic Association. The purpose of this series is simple. We take current research, pull it out of the journal, and ask what it means for doctors in real practice. This is not meant to replace reading the study. It is meant to encourage it. The links to the studies discussed in this episode can be found in the show notes. We encourage every doctor listening to review the research directly, look at the data, and think about how it applies to their own clinical process. Today, we are looking at shoulder examination, specifically rotator cuff tearing and subacromial impingement syndrome. For this review, we are looking at several sources focused on the clinical accuracy of shoulder physical examination. That includes a 2024 systematic review and meta-analysis in BMC musculoskeletal disorders, the JAMA Rational Clinical Examination Review on rotator cuff disease, and earlier studies examining the diagnostic value of lag signs for full-thickness rotator cuff tear. We are not going to turn this episode into a bibliography. The full citations are in the show notes. But the practical question running through these studies is simple. When a patient presents with shoulder pain, which exam findings should actually change your clinical suspicion, and which findings should be used with more caution? A patient walks into your office with shoulder pain. They cannot sleep on that side. They cannot reach overhead. They think they pulled something. They tried to wait it out, and it's not getting better. The question is not whether you know 10 shoulder tests. The question is whether you know what those tests actually tell you. Most clinicians were taught a long list of orthopedic shoulder tests: Neer, Hawkins, Jobe, drop arm, liftoff, painful arc, lag signs. But a positive test does not always prove the diagnosis. A negative test does not always clear the patient, and one isolated maneuver is rarely enough to make a confident clinical decision. That is why this study review matters. The research does not ask us to throw away the shoulder exam. It asks us to stop treating familiar tests like they are stronger than the evidence says they are. Shoulder pain is one of the most common musculoskeletal complaints seen in clinical practice. Rotator cuff tears and subacromial impingement are two major diagnostic considerations. The study review materials note that shoulder pain is the third most common musculoskeletal complaint evaluated by primary care physicians, and that a significant percentage of shoulder pain cases involve rotator cuff tears or tendinopathy. For chiropractors, this matters because patients rarely walk into the office with a clean diagnosis. They walk in with pain, weakness, limited motion, sleep disruption, and uncertainty. A strong shoulder exam helps the doctor decide whether the presentation looks like general rotator cuff irritation, possible impingement, a full-thickness tear, cervical referral, instability, adhesive capsulitis, or something that may require referral, imaging, or co-management. The central lesson from the literature is clear. No single shoulder test is perfect. Some tests are better at increasing suspicion. Some are better at lowering suspicion. Some are more useful for ruling in a condition. Others may help rule something out. And some familiar tests are not as reliable as many clinicians assume. Across the studies reviewed, the strongest findings for identifying full-thickness rotator cuff tear were the lag signs, especially the external rotation lag sign at 90 degrees and the internal rotation lag sign. The external rotation lag sign at 90 degrees showed the highest diagnostic accuracy for suspected rotator cuff tear, and with a diagnostic odds ratio reported at 1270. It was also highly specific, with reported specificity between 94% and 98%. Which means that when this test is positive, it can strongly increase suspicion for a full-thickness tear. But there is an important catch. Its sensitivity is relatively low. That means a negative test does not safely rule out a tear. That is a major clinical point. A positive lag sign should get your attention. A negative lag sign should not make you careless. The internal rotation lag sign also showed strong value, particularly for full-thickness tears involving the subscapularis. The research identifies it as one of the more accurate findings in the shoulder exam. So, the lesson is straightforward. If you are not using lag signs well, your shoulder exam may be missing one of the better tools available. This is also where the research gets uncomfortable. The JAMA review and the more recent meta-analysis both point toward the same larger lesson. Familiar tests are not automatically reliable tests. Tests like Neer, Hawkins, Jobe, drop arm, liftoff, and others all have their place. But the research does not support treating every familiar test as equally reliable. For subacromial impingement syndrome, tests like Neer and Hawkins showed diagnostic value. The painful arc test also mattered, especially in general rotator cuff disease. Jurgensen's test showed diagnostic value in the review, though the sample size was smaller. But the bigger message is this: a shoulder exam should not be built around one favorite test. That is the trap. A doctor does one test. The patient grimaces. The doctor says, that is impingement. Or the doctor does one test. The patient does not react. The doctor says, you are fine. That is not evidence-informed examination. That is shortcut diagnosis. The research points toward a better model. Use combinations of tests. Understand their limits. Place the exam inside the whole clinical picture. The specific problem this study helps fix is overconfidence in isolated orthopedic testing. Shoulder pathology does not behave like a simple yes or no question. Pain can come from tendon irritation, bursitis, partial tear, full-thickness tear, cervical referral, instability, AC joint involvement, adhesive capsulitis, or other causes. The exam has to sort through that complexity. So this study gives chiropractors an opportunity to tighten the process. Instead of asking, which test proves the diagnosis? Ask better clinical questions. What does this test increase my suspicion for? What does this test fail to rule out? What other findings support or challenge this impression? What would change my management plan? When should I refer, request imaging, or co-manage? That is where clinical reasoning becomes stronger. This is also where chiropractic has a meaningful opportunity, but we need to frame it responsibly. The studies reviewed do not say chiropractors are the best point of entry for shoulder pain. The source material is clear on that point. It does not directly evaluate chiropractic care as the preferred entry point. But the studies do reinforce something important. Musculoskeletal care depends heavily on skilled physical examination, especially early in the process. Chiropractors who are well-trained in orthopedic and neuromusculoskeletal evaluation can play an important role in early conservative assessment, triage, and management. That is the opportunity, not to overclaim. Not to pretend every shoulder belongs in conservative care forever. Not to ignore red flags. The opportunity is to be excellent at the front end of musculoskeletal evaluation. That means using evidence-informed exam clusters, knowing which tests matter most, documenting clearly, recognizing suspected full-thickness tears, referring when needed, coordinating care when imaging or surgical consultation is appropriate, and treating conservatively when the clinical picture supports it. That is how chiropractic strengthens its credibility. The practical takeaways are direct. Strengthen your shoulder exam around test clusters, not isolated maneuvers. Give special attention to lag signs when evaluating possible full-thickness rotator cuff tears. Remember that high specificity can help rule in, but low sensitivity means a negative test does not safely rule out. Do not over-rely on traditional tests simply because they are familiar. Use the exam to guide the next right step: conservative care, referral, imaging consideration, or co-management, and document your reasoning. A strong clinical note should show not just what test was positive, but why that finding mattered in the context of the full examination. That is where the study becomes practice. The value of this research is not that it gives chiropractors a magic shoulder test. It does the opposite. It reminds us that good clinical practice requires discipline. The shoulder is complex. Rotator cuff disease is common. Impingement findings can overlap. Pain provocation tests can mislead when they are used carelessly. So the opportunity is clear. Read the studies. Look at the diagnostic accuracy. Revisit your shoulder exam. Ask whether your process is built on evidence, habit, or a little bit of both. And then sharpen the process. Because the better we become at evaluating musculoskeletal conditions, the stronger the case becomes for chiropractic as a serious, evidence-informed access point for conservative care. Again, PCA Study Review is a service of the Pennsylvania Chiropractic Association. The links to the studies discussed in this episode are available in the show notes. We encourage you to read the research, bring it back into your clinical reasoning, and use it to strengthen the care you provide every day. Until next time, stay curious, keep reading, and keep sharpening the clinical judgment that protects your patients and strengthens the profession.